Hi class. For this recording, we're going to look at diverticulosis and diverticulitis. These are two related GI conditions that affect the colon most of the time. And because they're kind of interconnected and diverticulosis can lead to diverticulitis, they're kind of referred to together and discussed together. So let's dive in here. So this image, the diverticulosis that you could see on the left, that's the formation of all these little small pouches or outpouchings that they call them, and you could see they're bulging outward from the colon wall, and that happens primarily, they think, due to increased pressure in the lumen of the GI tract, and also that's in combination with weakened walls of the colon. So a lot of times this is actually asymptomatic and it can go unnoticed for years and years. And it occurs mostly in the descending sigmoid colon at those points where the wall is weak, although they can be anywhere in the GI tract, but we're going to focus on the sigmoid colon here. So, and then the image on the right, when the diverticulum become obstructed, that can lead to diverticulitis. So diverticulitis happens when these little outpouchings become inflamed or infected. So when that obstruction occurs, you have increased pressure here, you have a reduction in blood supply to this area, and then you have bacteria that are able to invade, and that can result in inflammation, of course, and infection. And so the problem with that, especially when we're talking about the gut, is that we can have complications like abscess formations, fistulas, peritonitis, and perforations. So diverticulosis is characterized by those small outpouching formations known as diverticula in the colon wall. And as I said, it's believed to be from that increased pressure and the weak spots that cause those little bulges. The risk factors include aging, low fiber diet, obesity, sedentary lifestyle, and there's also a genetic predisposition. So also a lack of physical activity weakens the muscles in the intestine and slows down bowel movements. So they do say regular exercise helps with that healthy gut and helps to reduce pressure in the colon as well. So diverticulitis then occurs when one or more than one of these diverticula become inflamed or infected. And that's often triggered by a blockage, possibly with fecal matter, and that leads to bacterial overgrowth and inflammation. So again, the risk factors are similar, but there's additional evidence to show that smoking and the use of NSAIDs and excessive alcohol use and obesity, also there's a higher incidence of diverticulitis in patients that use those things. So smoking reduces the tone and the nerve activity in the smooth muscle in the gut because of the nicotine there. So they find diverticulitis occurs in a younger age when they look at when you're talking about smokers versus non-smokers. And then with the obesity, you have excess weight puts stress on the digestive system, and that increases pressure. And also, the obesity is inflammatory, right? And they actually say that belly fat is like its own organ now, and it releases cytokines, which are inflammatory. And they theorize now that diverticulitis actually results from like a low-grade chronic inflammation. Okay, and then as far as the NSAIDs, when you have these, you know, diverticulum that are inflamed, then that can create problems with GI bleeding related to the diverticulitis. So again, that low fiber diet can lead to decreased stool volume and increased pressure in the colon wall. It's like I said, it often goes unnoticed for years. It tends to get diagnosed because they happen to have a scan for another reason, or they're having like a routine colonoscopy at age 45 and up, or perhaps they come in because they actually have a GI bleed because of diverticulitis, and then it's determined that they had the diverticulosis. So, what else do I want to say about that? Yeah, as I mentioned before, that inflammation triggers cytokine release, and so when we have that release of those cytokines, that can cause fevers and increased white blood cells. So when you're looking at your patient with diverticulitis, you would expect to see that. So diverticulosis, again, often asymptomatic and is caught by chance. Some individuals might complain of mild symptoms like bloating or constipation, or abdominal discomfort. And then in contrast, diverticulitis presents with more pronounced symptoms like acute abdominal pain. And if you think about the fact that it most commonly occurs in the sigmoid part of the colon, you're going to see that pain in the left lower quadrant. All right. They may also have a fever, nausea, vomiting. They might have changes in their bowel habits like diarrhea, constipation. And the severity can vary depending on how bad the inflammation is and how bad the complications are. So we're going to look at that now on this slide here. So as far as that left lower quadrant pain, that pain might worsen when the patient is straining to have a bowel movement, or they're lifting something heavy, or even if they're coughing as well. They may complain of blood in the stool. And then some of these symptoms that you see there could be indicative of perforation or peritonitis, like the fever, the chills, that hard, rigid, distended, tender abdomen. The patient might have guarding, etc. So assessment of a patient with diverticulosis or diverticulitis, you want to get a thorough history and physical, looking at the patient's age, dietary habits, bowel patterns, history of abdominal pain, or whether maybe they had a history of diverticulitis in the past, physical exam, again, that left lower quadrant pain. Lab tests might show elevated white blood cell counts. It can also show our inflammatory markers, our CRP, and our SED rate, or ESR, can be elevated as well. Imaging studies like CAT scan are often used to confirm the diagnosis and to tell us the extent of the inflammation or complications. They can do barium studies to visualize the colon and look for the diverticula. And again, the CT scan can help distinguish between diverticulitis versus other conditions. Okay. If they suspect that peritonitis is present, which in addition to that left lower quadrant pain, they might have left upper quadrant pain along with that rigid abdomen and that guarding and stuff, they're not going to do a colonoscopy or a barium enema because that can increase the intra-abdominal pressure. So in that instance, they may just take the patient for an exploratory laparotomy surgery just to get in there and figure out what's going on. So complications of diverticulitis, again, can include abscess formation, bowel obstruction, perforated colon, fistula formation, and peritonitis. These can increase morbidity significantly, sometimes requiring surgical intervention. So it's important to catch that stuff early. Additionally, that diverticulitis, as I said, can cause a GI bleed. So those submucosal vessels in the diverticula can rupture. And if that happens, then you'd see that hematochezia, and your patient could also be anemic. With the diverticular abscess, that outpouching and that inflammation and distension from that outpouching compresses the blood flow in the diverticular wall, and that causes like ischemia and weakening of the diverticular wall, and that can cause the diverticula to actually perforate, and then the bacteria moves across that wall there in that area and can form a little pocket like an abscess. If this were the case, you'd expect to probably see that left lower quadrant pain, fevers, leukocytosis, and you might be able to palpate a left lower quadrant mass. And this would require like a percutaneous drainage and in interventional radiology. And sometimes if it's big enough, even like a surgery to wash out the abscess. Also, kind of along that path, though, I just explained, when you get to the point of where the ischemia and weakening occurs, and that perforation can happen, a tissue connection can actually form between the sigmoid colon and the bladder, which is a fistula. Specifically, that type of fistula is called an enterovesical fistula. And this patient would present with recurrent UTIs due to fecal urea, because that fistula, there's actually stool from the gut that's, getting into the urine. So frequent UTIs, you might want to question that. And then they might also have something called pneumaturia, which is air, because the air from the gut is getting in to the bladder. And so you might actually see like bubbles in the urine, and that would require surgical intervention. So recurrent episodes of diverticulitis can lead to chronic inflammation and scarring in the colon. And when you have that scarring, that can make the lumen more narrow, and that would make it would make it harder for the stool to pass through. So that narrowing or that stricture can lead to bowel obstructions. And again, the same with the fistulas, the abscess, and the peritonitis. So sometimes surgical intervention is warranted in diverticular disease. So if other approaches with modifying lifestyle, modifying diet, and treating the inflammation doesn't work, then they might need to actually remove that part of the colon that is diseased. Okay, so sometimes they can do like a laparoscopic partial colectomy, where they take out partial, like a part of the colon. And then at other times, if it's, severe cases, the patient actually might wind up needing a colectomy and wind up with an ostomy. So nursing interventions with diverticular disease, if a patient is coming in with a flare-up of diverticulitis, they're going to be NPO. We want that bowel to rest to get that inflammation to go down. So we're going to be giving them IV fluids like normal saline to help with prevent dehydration. Once the bowel is rested for a bit, we'll start with like a clear liquid diet and advance slowly to diet as tolerated. So I will say that with diverticulosis, we encourage the patient to have a high fiber diet, which is we'll discuss on the next slide. And that will prevent and reduce the risk of diverticulitis occurring. However, with diverticulitis, when you have that flare up, you don't want them to have a high fiber diet. You want like a low residue diet to make it easier on the gut. So diverticulosis, again, they're pretty stable. Usually it's found just by chance. We tell them as an outpatient, high fiber diet, increase fluid intake to prevent constipation and stuff like that. What I'm talking about here is we're looking at a diverticulitis flare-up. So again, NPO, IV fluids, antibiotics, and there's different research on this, discussion about whether or not to give antibiotics. So if it's a pretty straightforward case of diverticulitis, they may not give antibiotics, but just for our purposes, we'll just expect to give antibiotics. So typically that's going to be your fluoroquinolones, which are, treat against gram-positive and gram-negative bacteria. It's a broad spectrum antibiotic. And then also they'll give Flagyl, and that is effective against anaerobic bacteria and parasites. So usually when we're talking about gut stuff and potential infection in the gut, they're given the fluoroquinolones and they're given the metronidazole, the Flagyl. We're also going to be administering pain medication, so like morphine or Dilaudid, and then also antiemetics like your Zofran. If the patient is constipated, some medications, and these medications are going to depend on, what the situation is at this point, but to prevent constipation, like in the future, we would give stool softeners like Docusate, and those work by lubricating the intestinal tract, and that softens the feces, right? But those could take a couple days to work. Then you've got the option of like a Metamucil or a Psyllium, which is a bulk-forming laxative, and that absorbs water, increases bulk to stimulate peristalsis, and that works within about 24 hours. But again, during an acute phase of diverticulitis, that's not something that we're going to give the patient. But if constipation was an issue that got them to this point, then, these are things that they can take as outpatient, as preventative. What else? Dulcolax, so bisacodyl, that's a stimulant laxative that irritates the colon wall to stimulate peristalsis. If it's given orally, it works within about 12 hours. It can also be given rectally, and it works a little bit quicker. And then you have mag citrate, which is an osmotic solution. So that works really quickly to draw fluid into the intestine, and that can work anywhere from like 20 minutes or so to like 3 hours. Again, whatever treatment is happening is going to depend on the severity of the condition. So if it's caught early, they might even give oral antibiotics and just have the patient as an outpatient on a clear liquid diet. But typically, if we're talking about hospital cases, more severe cases, we're given the IV antibiotics and possibly surgery to remove that part of the colon. And again, if we are giving pain relievers, remember a side effect of that is constipation, so we want to keep that in mind. We want to monitor for intake and output, of course, and then monitor for signs of perforation. So is the patient distended? Do they have a fever? Are they restless, tachycardic, etc.? If we need to prepare them for surgery, we obtain an informed consent. They might need an NG tube. We might need to prep them, for the idea of having an ostomy as a possibility. And sometimes they may place a temporary colostomy, give the patient a few months for the bowel to rest, and then re-anastomose. They'll reconnect everything and close up the ostomy. So post-operatively, we want to monitor the surgical site. We, of course, want to monitor the ostomy site to make sure it's viable, that it's, beefy red and all that good stuff. And then we're going to have to teach the patient how to manage their ostomy as well. And then, of course, with any post-op patient, we want them to mobilize early, so get them up and walking to prevent post-op complications like atelectasis, DVT, etc. Dietary management is a cornerstone in the treatment of diverticulosis and diverticulitis. A high fiber diet is recommended to promote regular bowel movements and reduce pressure in the colon. So high fiber foods might be things like fruits, veggies, whole grains, legumes. During an acute attack of diverticulitis, though, a low fiber diet or clear liquid diet is recommended for the colon to rest. And once the symptoms improve, they'll start to gradually reintroduce fiber into the diet. So as the patient goes home and they start adding those low fiber foods, they can eat things like canned fruits or even like cooked fruits and veggies, but they will suggest like without any seeds or without the skins on them. They don't advise that patients eat, as they're healing from a diverticulitis, like raw fruits and vegetables right away. And they say it's okay to drink strained vegetable juice, but like they don't recommend having pulp in the juice, and they also suggest diluting the juice like half water, half juice. As far as eating protein during the recovery period, they suggest like well-cooked fish and poultry and red meat if it's lean and slow cooked. And eggs and tofu and nut butters without any seeds in them, or without any crunchies in them, rather, are acceptable too. Most dairy products are okay, but like if they're eating a yogurt, they don't want to add granola or nuts to it. Cheeses are okay. But then, they suggest like low fat or fat-free milk during that recovery period. So low fiber grains that are okay during recovery period are like white bread, rice, and pasta, grits, cream of wheat, and then like cereals that are from like white flour or refined flour. Of course, small frequent meals, drinking lots of water, and then wait for clearance or wait for, the healthcare provider to let them know when it's okay to eat a high fiber diet again. Sometimes these patients will actually come back after 6 to 8 weeks and have a follow-up colonoscopy to see how things have healed up and determine whether or not they might need a surgery. We would also want to teach the patient as they start eating, if they have those signs of like fever or pain becoming worse, or they can't keep stuff down, to follow up with their healthcare provider. So as they're healing up, again, fruits, veggies, and whole grains are fine. Drinking lots of water. We want that fiber because it acts like a bulking agent. It helps add volume to the stool. And then you have smoother bowel movements, and then the pressure in the colon is reduced, and then the risk of diverticular formation is reduced. So if you're not getting enough fiber from a diet, they may suggest like a fiber supplementation, like the psyllium or Metamucil. Now, in the past, people were told to avoid nuts and seeds and popcorn, and like the jury is still out on that. Some experts say that there's no harm in eating those. That's not during an acute phase of diverticulitis, but just in general when things are healed up. So I'd probably, for NCLEX purposes, stick with the theory of not eating that stuff during a flare-up. And as far as teaching and prevention, because we don't want a recurrence to come back, that diet teaching is important. Regular exercise, as I mentioned at the beginning, improving muscle tone and weight reduction can help reduce the likelihood of a recurrence. And the smoking cessation as well, as I mentioned. And teaching the patient to defecate when the urge occurs and not holding it in. They may want to avoid activities that can increase that intra-abdominal pressure, and that might cause another attack of diverticulitis. So things like straining, bending over, and heavy lifting. And as I mentioned, teaching about follow-up care, when to report back to the healthcare provider, and possibly needing a follow-up colonoscopy based on what the specialist advised to see if a surgical intervention is warranted down the road. And that's it.